diagnosis and management. So let's go back to when it all started. Our patient is a 38-year-old female patient living in Alexandria. She's a worker, married with 2 offsprings. She came presenting with recurrent episodes of uncontrolled hypertension and muscle weakness. Going back in history to her early 20s, the patient has developed hypertension in her early 20s, the cause of which was never investigated. For her hypertension, she sought the medical advice of different endocrinologists and was prescribed several antihypertensive medications that she couldn't specify, yet she could state clearly that she wasn't completely compliant and had poor follow-up of her hypertension, and so her hypertension was never properly controlled. Going forward to her early 30s, she began to get several attacks of muscle weakness that were found to be due to severe hypokalemia. That these attacks required hospital admissions and sometimes even ICU admission. During her recurrent admissions over a period of 8 years, the cause of hypertension nor the hypokalemia was properly investigated. The management during her repeated admissions only focused on controlling the blood pressure and retrieving the potassium stores with IV potassium chloride, and upon correction she was almost discharged. In 2022, she had her last and most severe attack, for which she was admitted to the ICU for a couple of weeks. She had severe potassium of 1.8 milliequivalent per liter. This time, she didn't respond as usual to the IV potassium correction, and she had an attack of hypertensive emergency that her blood pressure was uncontrollably high. Her labs were, as we mentioned, for the serum potassium, where it was 1.8 milliequivalent per liter. Here we had a few resistant hypertension and hypokalemia that made her physician decide to consult an endocrinologist, and based on these facts, he requested serum aldosterone that was significantly high, of a value of 578 picogram per milliliter. He also requested renal activity that was 2.41 nanogram per milli per hour, with a ratio that was significantly elevated of 239.8. Accordingly, CT abdomen and pelvis was requested that showed enlarged left suprarenal gland with a mass averaging 2 by 1.5 centimeter in dimension. This is the coronal section of the suprarenal gland. Another transverse section showing the mass. Although the lab results together with the CT abdomen and pelvis were enough to establish a diagnosis, they proceeded further, and MRI of the suprarenal glands was done. The medial limb showed the medial limb of the left suprarenal gland harbored a focal lesion averaging 2.7 by 2 by 1.5 centimeter, showing drop in opposed phase exposition features impressive of left adrenal adenoma. This is the section showing the enlarged suprarenal gland. Preoperatively, the patient was offered a medical treatment in the form of spironolactone of 200 mg together with valsartan 160 mg. Her blood pressure was controlled and her potassium levels rose to a normal value without any potassium supplementation, and the patient was scheduled for a laparoscopic left adrenalectomy. By the end of February 2022, she underwent left adrenalectomy, after which her potassium levels normalized and she was rendered normotensive. To sum up, our patient presented with a resistant hypertension, hypokalemia that were found to be due to primary hyperaldosteronism after several years of delayed diagnosis. In our case, we have faced several pitfalls that hypertension in a young age, for which the cause was never properly investigated. Hypertension and hypokalemia were never correlated until late in the course of her illness. So our take-home messages is that hypertension in a young age should be investigated for secondary hypertension, and that hypertension and hypokalemia should be investigated for primary hyperaldosteronism, although only a third of the cases present with hypokalemia and pain.
الأول بيقول اتفضل عندك hypertension
was starting treatment which should include the serum isotypes.
Cancer. طب أنا the question given yes. Answer this question.
Yes.
Hypertension and hypokalemia are the causes.
There are several causes.
What are the
One of those can be hyperoxia.
Yes, you do.
Number two, you should do
Let me should do what are.
what are. You should think about another those like genetic syndromes.
Well,
Genetic syndromes.
stomach.
Genetic syndromes like headaches. Headache is hypotension. Another causes you can drug abuse.
طب احنا مش عارفين خلاص. Let's go to this perspective.
Professor, from the endocrine point of view, would you comment on when to suspect endocrine hypertension for the general practitioner and for the internist as well? Thank you.
Thanks very much. When I first came into endocrinology, we thought less than 1% of patients with hypertension had hypercortisolism. We now know it's at least 10%, and it may be more. So one has to have a very low index of suspicion. Secondly, even then, even in North America and Western Europe, the number of patients investigated is very, very low. So we are all very, very bad. You could make out a case for every patient with hypertension to have a renal and aldosterone. That may be too much, too intensive, too expensive. But at the very least, any patient who is young, under the age of 40, any patient who is hyperkalemic at any age, even on diuretics, and any patient who is on, let's say, 3 or more antihypertensive drugs. So I think basically one needs to have a very low index of suspicion. The problem is, in this case, I have to say, it's beautifully done, but it was pretty obvious. She was very hyperkalemic, she was young, she had an adrenal mass, case proven. The difficulty is when you have the older patients who may or may not be hyperkalemic, who does not have an obvious mass on the adrenal, then the investigation is very difficult because you have to think about venous catheterization studies, which are complex and expensive. So the bottom line is have a high index of suspicion, particularly young patients, especially hyperkalemic, and especially when they are resistant.
Just one point. Our professors, when I was young, when I was resident, Professor Sin, by the way, but do you look for the urine in hypertensive patients? No, they are looking. Alkaline urine is a very suspicious of what's on the blood. I'm not doing it frequently, but in the past, without anything, just looking for the pH of the urine. Alkaline or acidic difference of this. Let's go.
So, this case has enlightened the fact that in hypertension, think about endocrine cause, pituitary, Cushing, acromegaly. Don't forget, as I mentioned earlier, the parathyroid gland, because it's another hidden organ. And now we are concentrating on the problem of aldosterone.
Although it's slightly off the point, I think it's very interesting that we ought to see an increasing number of adrenal incidental overs. And the recent studies have shown that the diagnosis of that very, very rare disease, pheochromocytoma, it's now diagnosed in 40% of occasions on adrenal incidental overs. So if you see an adrenal mass, you have to think of Cushing's, you have to think of aldosteronomas, you have to think of pheochromocytomas.
And the adrenal is not only pheochromocytoma. Now we have the chance, by following Professor Halawa, is an eminent professor of endocrinology at the University of Ain Shams in Cairo, and he will be updating us about the recent advance about hyperaldosteronism, and in the old time used to call Cone syndrome. I don't know, still using Cone syndrome in UK. For you, no more Cones. Professor Halawa.
The important points were really has been raised during this nice discussion. وهبدأ محاضرة بحالة قريبة من حالة الدكتورة تايرويد. استاذ الحالة بتاعتنا هو فيميل 53 سنة referred for further investigation of primary hyperaldosteronism. Patient initially diagnosed with hypertension 3 years ago following routine medical assessment. At that time, the lab work showed elevated aldosterone to renal ratio, mild unprovoked hypokalemia while taking no medication. Following the discussion with primary care physician, she declined further investigation and elected to proceed for medical therapy. However, she is now keen to explore the possibility of adrenal surgery. Current medication amlodipine 10 once per day, pipronol 50 once per day, potassium chloride 2 times per day. The medical history unremarkable. الفيزيكال اكزامينشن بلاد بريشر تقريبا 150 على 90. البادي ماس اندكس تقريبا 30. اذروايز الفيزيكال اكزامينشن ار ريماركبل. البوتاسيوم 3.8. البلازما رينج 0.5 نانوجرام بر ml per hour. الالدوستيرون 42.5 nanogram per ml. With serum cortisol after dexamethasone suppression is 1.2 microgram. CT abdomen showed remains of 1 centimeter in the right adrenal gland. To address the summary of my group, this is the questions need to be asked. Which of the following is the most appropriate next step for this patient management? Refer for right adrenaline, increase the dose of pipronol, do saline infusion suppression test, proceed for adrenal desampling or switch pipronol to doxycycline before proceeding to renal desampling. حد يحب يتعلم أو ما كانش كده بفكر which the best ترى لو غلط فيه. إيه رأيك؟ It's okay. بسرعه كده primary aldosteronism ده excessive unregulated secretion of aldosterone hormone. والprimary aldosteronism the commonest second cause of hypertension. البريفلنس بتاعنا في different estimates ده طبعا نتيجه في heterogeneity في السورس بتاع بتاع الداتا، لكن بيتراوح في البرايمري كير من 3 ل 14 وفي الهوسبيتال او السبيشاليتي كير من 10 ل 20. Unfortunately, we can address the point as said by Professor Samir, and I think this is the goal of this session. Primary aldosteronism is underdiagnosed and under treatment with the current clinical practice. Actually, because there is under-screening and diagnosis, and the principle of this screening let us do because most of the guidelines of hypertension is oriented with the targets oriented for the management. Again, lack of specific guidelines for awareness for the diagnosis and management and those of the Ukrainian society. طبعا احنا زي ما احنا عارفين سمير aldosterone occurs as named for the adrenal adenoma for the initial describing of the primary aldosteronism and represents 35% في public hyperaldosteronism bilateral hyperplasticity. Adrenal carcinoma is rare and again is important cause is the familial hyperaldosteronism عندنا تقريبا many mutations أهمهم اللي هو glucocorticoid remedial hyperaldosteronism لأن ده عبارة عن كاينيتيك بروتين أو جين مش هخش في التفاصيل، لكن الباثولوجي بتاعنا هنا depends on the retention of sodium, excretion of potassium and hydrogen ions to producing hypokalemic alkalosis and acid. The presence of potassium is less than 10-50%, so it's very small amount, so it's not an important sensitive marker. Again, the expansion in sodium leads to suppression of the renin synthesis. So the end we will have a hyporeninemic hyperaldosteronism state. The clinical picture is moderate to severe hypertension, often linear, either spontaneous or provoked by diuretics, may be asymptomatic or associated with tetany, weakness, tachycardia, may be important. Again, this is the most important of searching for and treatment of hyperaldosteronism because it's associated with many comorbidities, increasing the cardiovascular morbidity and mortality compared with primary hypertension, heart disease, AF, and stroke. Again, associated with other comorbidities like obstructive sleep apnea, renal, metabolic, and bone complications. Diagnosis depends on the use of screening and diagnostic threshold for biochemically confirming or excluding the condition. And this is a simple three-step diagnosis. It's simple three-step but challenging with every step with the holding. The initial screening is aldosterone ratio to exclude or to confirm if unlikely, and again to confirm with the confirmatory test to prevent further evaluation or invasive approach for localization, whatever either is CT or adrenal vein sampling. In a hurry, I will just go on fast. It Society guidelines for diagnosis recommend screening for up to 50% of at risk of primary aldosteronism. Severe hypertension with spontaneous or provoked, hypokalemia, adrenal mass, sleep apnea, history of early onset hypertension, stroke at the young age or first degree relatives. Keep in mind that screening recommendations should be carried with aldosterone ratio. This is the key for screening. It's a simple calculation. It should be done in the same sample. Plasma aldosterone concentration nanogram per ml over plasma renal activity nanogram per ml per hour. With a ratio more than 30, this suggests primary hyperaldosteronism. Again, recently the direct measurement of renal concentrations have been used by many labs, but it's still unfortunately is not standardized. The method here for the test should be carried in normal kalemic circulation, so we have to correct the hypokalemia. Regarding the current practice is done in the sitting mid-morning, 15 minutes, 2 hours, and calculating. Opinions differ relating to optimum conditions for aldosterone ratio. However, many advocates that no need to stop concomitant antihypertensive medications with the first screening for paired plasma aldosterone and renal ratio. However, or traditionally, endocrine society recommends to start glucose receptor antagonist at least 4 weeks. Test results should be interpreted depending on the effect of antihypertensive drugs. في يمكن الدراجز اللي احنا عارفينها في حاجات بتديلي فولس بوزيتيف وفي حاجات بتديلي فولس نيجاتيف. الفولس بوزيتيف اللي هي الحاجات اللي بتقلل الرينين لانها بتساتوريت السبريشن بتاع الرينين، والعكس صحيح الفولس نيجاتيف اللي هي هتزود لي الرينين لان ده بيعتمد على الريشيو. البيشنتس with hypokalemia and resistant hypertension مش بالضروري ان انا اوقف النيران كورتيكويد لو انا حاطه العيان ممكن يبقى ادريس. Again, finding of high plasma aldosterone concentration ده بيعني ان العيان in the presence of other medications can compromise ده برضه بيقلل الدايجنوز of primary aldosteronism. Aldosterone ratio should be repeated if initial results are inconclusive or difficult to interpret. طبعا taking into consideration the confounding medications في initial screening. Confirmations is important to exclude and avoid the invasive workup to confirm the presence of primary aldosteronism, specifically adrenal vein sampling, and this البرنسبل ان انا بعمل نوع من انواع البروفوكي او سبريشن او aldosterone secretion which is not responding with overloading with sodium and fluids. Confirmatory test, saline infusion test, with cortisol or salt suppression and captopril. But again, the definitive evidence that one single is optimal is lacking. تقريبا كل حسب السنتر and the choice of confirmatory test بتعتمد على البيشنت كومبلاينس اللاب واللوكال اكسبرتيز وده اعتقد ان احنا we are somewhat lacking in each. انا مش هخش في التفاصيل بتاعت الديفرنت لكن انا حطيتها طبعا لان الانتربريتيشن مهم. يمكن الحاله اللي قالتها الدكتوره روان جاي هنا بيزد على الاندوكرين جايد لاينز. No need for confirmatory test لو أنا عندي عيان positive aldosterone ratio و high plasma aldosterone concentration in the spontaneous hypokalemia ممكن proceed for localization. Localization or lateralizations اللي هي هتأدي في الآخر إن أنا لو عندي a possibility for adrenal surgery. It includes imaging, adrenal gland sampling and radiolabel scanning. The imaging on the top is CT or MRI. وده بيديني ريفيوز اكتر من نص. انا I have to stress this point that MRI وده للاسف بيجي كتير في الريبورتس بتاعت الراديولوجيست بيعمل CT يلاقي حاجه يقول لك مكتوب MRI has no advantage over the CT in the evaluation of primary aldosteronis because it's expensive and no additional or less special resolution than the CT. طبعا السي تي اي تيومر more than 4 بيريز the possibility of cancer. طبعا السي تي finding يا اما نورمال او يكون لاترال ادينوما او مايكرو ادينوما او combination في bilateral and imaging is not adequate for referring the patient for surgery لان انا عندي بالانكريجن ايج خاصه فوق 50 في انكريز في الادرينال incident turnover. Adrenal gland sampling is the diagnostic key to identify patients who should or will refer unilateral laparoscopic adrenalectomy. And this is recommended with the Endocrine Society for all patients fulfill. Number one, اللي هو recommended patients bilateral adrenal changes older than 5. In patients apparent solitary adenoma and because of increased incidence of incident. Again, the patient should be feasible and desirably treated of research. دي الحاجات المهمة قوي بالنسبة للادرينال سامبلينج تبقى ستاندردايز ان استابلش سنتر في بعض الداتا المهمة علشان الريشيو واللوكاليزيشن واللاتراليزيشن اندكس يمكن حاجات تكنيكال لكن مهمة قوي ان الادرينال سامبلينج will not be necessary if there is unilateral أكثر من 10 سم in young patients اللي هي أقل من 30 سنة وسبب الكلام أعتقد الحالة دي تمشي مع الحالة بتاعت الضرر. آخر حاجة الريجوليتد سكاننج عندنا سي اي سي ده طبعا أحد الإيبيكوز اللي هو للريجوليتد استروجين وبروميسنج سبيسيفيستي لكنه ما هواش available state اللي هو considered. To conclude with this algorithm from the Endocrine Society, first screen aldosterone ratio. Plasma aldosterone unlucky is likely to proceed for a confirmatory test unless there is hypokalemia, hypovolemic, severe hyperaldosteronism. I can skip a confirmatory test for localization or go for localization and do for imaging, CT, or adrenal gland sampling. And I think the choice for my patient is adrenal gland sampling. We will skip the stimulation of confirmations, and this is the most important for our patient. And with this, I reach my end of the talk, and thank you very much.
In my life, I have 6 cases, and I remember 6 cases. And before medical referred to Samir Naino, 2 cases outside. When one of my patients who had spirola for 10 years, after PCI stents, 3 vessels, was taking spirola 6 tablets per day. في 2 patients عملوا surgery. دكتور سعد، واربعه ميديكال تريتمنت. ده ماي لايف، انا بتكلم كارديولوجيست، ما اعرفش الفريكونت كنت بتشوفوا قد ايه، بس يعني الكلمه دي زمان حاجه اسمها اوكر فايبرومسل سسبكت. ممكن نجيب الاخر سلايد نسمع اسمكم قبل ما الدكتور الكارديولوجيست، لان انا معلش كل الكلام اللي قلته ده مع احترامي لحضرتك اخر سلايد ده حضرتك اهم حاجه واحده عشان الناس دي تاهت.
أو بنسميها 3 ستيب أبروتش فور دايجنوزس سكريننج، لكن له المفروض تشالنجز. أول حاجة إن إحنا ألستيرين رينين ريشيو، اتفقنا إن ده أكتر من 30، لأن الستيت أوف this is hyporeninemic hyperaldosteronism. وهيسمح لي الدكتور صبحي أكمل السؤال اللي كان سأله secondary أو hypertension with hyperkalemia.
أنا تعتبر ده resistant detected ولا secondary hypertension؟ يعني الكيس دي secondary ولا resistant؟
دي secondary.
أصل هي العنوان هنا neglected resistant، ده غلط.
مفيش
غلط، resistant مش دي.
مفيش حتى عنوان.
ده عنوان الكارد اللي عندنا الدكتورة
بتاع
غلط. خلاص العنوان تعتبر غلط. زي ما كنا واحنا طلبة دلوقتي ارض كود السكندري بوتنشال دي واحده منهم، فمش هعتبر ريزيستنت بعد اكسكلوجن وده سكندري، وبعدين تيجي 3 دراجز زي ما الدكتوره قالت انكلودنج دراجز يبقى ريزيستنت اللي انا هشتغل عليه ككارديولوجي ادرينال دينرفيشن. خلاص كده عشان بس نتذكر نبقى اصحاب مع بعض. يبقى دي سكندري. اتفضل يا بيه.
احنا عندنا الحاجات الثانيه الهايبرتنشن
عشان هدافع عننا.
لا
You shouldn't wait if you suspect endocrine hypertension. You shouldn't wait the patient to be resistant because treating the endocrine disorder.
لا انا بقولش ريزيستنت.
Okay, so I'm not treating the hypertension. We are treating the patient. Okay?
لا مش فاهمني. احنا كارديولوجيست الترمينولوجي اسمه ريزيستنت لما if you exclude secondary taking the drug او دواء بقى سيرجري او ميديكال خلاص ما it is not resistant. It is secondary. It is pushing syndrome. It is private coarctation. ده secondary. خلاص ده secondary. لكن انت ليه resistant يعني after the secondary والprimary okay taking the drugs وهو معاه بالون دول خلاص يبقى ده ريزيستنت. ايه في تريتمنت ريزيست بس اكسكلود ان هو تو ريزيستنت مش ما بياخدش دراجز من تيكينج ذا دراجز. Then there is now renal denervation class 2A is to make it renal denervation. We have the trials ultrasonic او renal denervation. بس عشان كده بس نتفق على الترمينولوجي نخلص بيه. اتفضل.
يعني the aim of this setting is to address for under-diagnosed, under-treated important cause for hypertension in associated comorbidity to address this because it's not well advanced in the general hypertension guidelines. عشان كده لسه احنا ما عندناش حاجه فبندور لان يبقى في حاجه نبتدي ندور عليها. ريزيستنس سيفير يانج ايج زي ما هايبوكاليميا، لكن الحاجات دي ممكن ما تبقاش موجوده. فاحنا النهارده هايبورينيميك هايبوالسترين هيدينا ريشيو اكتر من 30. هعمل كونفرميشن. هدف الكونفرميشن ان انا ما اعملش حتى لان لو عندي فولس بوزيتيف كيس ما عنديش الخطوه الثانيه ان انا اقدر اعمل لها ايمجنج او اعمل لها ادرينال سامبلنج خاصه لو اتش فوق 50 لان انا عندي الريسك اوف ادرينال انسبكترما بتبقى عاليه. بمعنى ان انا ممكن يبقى عندي ادرينال ميس لكن مش هي السورس بتاع السكريشن بتاع البروتيول. فهنا لو انا عندي سيفير هايبورينيميك يعني سبريسد رينين هاي بلازما الستيرول كونسنتريشن ده ممكن اسكيب الكونفرماتوري واخش على اللوكاليزيشن. اللوكاليزيشن الكي عندي ايمجنج السي تي لان انا ممكن هيبين لي لو عندي فوق 4 سم ده ممكن اسسبكت كارسنوما من كاترين في الادرينال.
طب امتى البيت بقى؟ وين يو ذا بيت؟ خلاص انت سي تي خلاص.
البيت ملوش مكان.
انا كنت بيت.
ده احد الحاجات في سبيسيفيك بيت.
لا طلبها جميله قبل كده في الموقع. السي تي از نوت افيلبل. لو انت سي تي مش مبين انت متاكد ستيل دير يو دو بيت. البيت بتلاقي اوكر فايروس في اماكن ثانيه.
البيت سكان اللي هو الاف دي جي ده مش موجود هنا لان احنا بنستخدم البيت سي تي ميتوميديت ده ده سبيسيفيك تريسر. السبيسيفيك تريسر ده مش موجود في مصر، مش موجود من فيو سنترز، انما في مصر مش موجود، ما بيستخدم. مش البيت سكان اللي احنا بنطلبه، البيت سي تي اللي هو بنطلبه كله اوكي. فالسي تي هنا لو انا عندي سي تي باين الناس ولا ما باينش، بعمل بعد كده لازم ابقى كونسيدر الادرينال بين سامبل باللوكاليزيشن. unless ممكن اعدي الستيب دي زي الحاله بتاعت لو انا عندي يونج ايج اقل من 35 وبالتالي الانسيدنتالوما قليل سيفير هايبرتونيا البستيرونيزم والهايبرتونيا هيبقى بروسيد فور سيرجري لو انا موجود عندي.
شفت ليه خدت وقتك فيها ازاي؟ يعني اللي انت قلته شكرا لك.
كمل دلوقتي.
دكتور احمد نجيب اتفضل. لا نجيب ده مدرس